Good evening. Good evening, all. Good evening, Dr. Praveen,
Very
Dr.
good evening, sir.
TIWARI, Dr. Satish sir, Dr. Anil Lamba. Am I audible?
Good
Yes.
evening, Deepak. You are audible.
You have a talk on Wednesday or Thursday, sir, Satish sir, online, Infonar somewhere. I saw in somewhere.
Yeah. So it's a medical legal chapter webinar on AI, and
Yes,
they
sir.
have requested me to speak on ethical issues and medical legal issues. So
Yeah, sir.
it doesn't require my expertise, but more of a philosophical kind of view on this. And since I have learned from you,
Yes, sir.
and I read a lot about AI, so I'll try to do justice to the topic.
No, you will do, sir. You are a digital pediatrician.
Yeah.
It is not a very this thing.
Yeah.
Any help, sir? You let me know.
If you have any resource like say medical legal issues or what are the I'm still preparing the talk.
Sir,
So
tomorrow we have a talk on that, sir, by Dr. Krishna.
okay.
Krishan Rajpur is a Supreme Court medical legal consultant and ENT specialist.
Okay, so
Tomorrow we have a
I'll attend that. But meanwhile, when I'm preparing my talk, if you have
yes.
something about what is the Indian scenario of medical legal
I will share
aspect
you,
of
sir.
using AI.
I will share you, sir.
If you have something ready, I think. Otherwise, I will. And now that you have taught us how to find the sources, I'll manage.
No, you
But if
just
you
go
have
through,
something
sir.
ready, please share. Yeah.
You just go through it. Anything you want additional material under regarding Sahi, both. Huh? These are the
So you
newer
have said
things.
something? You have already said something?
Sahi, that is a
Sa-
strategic, it's from Government of India, Family
Okay,
Affairs
okay,
and Welfare and National
okay,
Medical. That is a strategic assessment of AI in health.
okay,
It's a
okay, okay.
SAHI, SAHI.
So I'll get all the sources
Then
there.
one more is both. What is both? BODH. Both means BODH means benchmarking of
Yeah.
all these AI
Okay,
tools models. This is from
okay,
IIT Kanpur.
okay,
These are the people who are given authorization.
okay.
Apart from the DPDP Act, it is easily
Yeah.
available to the
Mm-hmm.
website.
Right.
So that is the infantile stage.
Mm-hmm.
The main thing is you have to see the main controlling of HIPAA guidelines from US
Right. Right.
and GDPR from European Union.
Right. Yeah,
These are
that I
the
have read. Mm-hmm.
main AI controlling and regulating bodies. From there,
Mm-hmm.
our people are extrapolating as per the
Mm-hmm.
Indian constraints.
Right. Right.
So that we have to highlight it. What is the comparison
Yes.
between that?
Yes. Yes. That I have planned. That I will go through these sources and make some.
And only thing, if you go through this ABDM enabled software, no,
Mm-hmm.
you need not have to take a separate consent from the
Yes.
parents or the attenders.
So now I have started using cloud-based software from Dr. Bhavin, and he is going to make it
Yeah,
ABDA
Vatsalya.
enabled.
Yeah.
Vatsalya, yes. I have
He's
switched over from
launching.
April onwards. I have switched over,
Yes.
and there are issues. I mean, the ease with which we used to use Exxon, that
Yes.
user friendliness is little bit lacking. But I think it's a part of the transition. We have to struggle a bit, but quite okay. I mean, because there will be so many other benefits which I'll get from this cloud-based software. So.
Yes. So I think 15 people are joining. I will admitting them because Dr. Praveen has another engagement at 9:30. Has to leave. So
26,
good evening. Good
26,
evening.
20. Mm-hmm.
Thank you, Satish sir.
Okay, okay.
We will start the session because 8:30 to now. So good evening all. Welcome to our specialty series second. Already in Sunday we finished pediatric endocrinology and metabolic disorder. Lot many the Claude skills has been shown with by Dr. Om Lakhani beautifully. Probably some of you may did not digest that depth of knowledge what he has. Anyway, I will make another live webinar, free webinar, and there we will teach you how to use this Claude MD skill in that in your domain. That is one thing. Second thing, we had a very good session with Dr. Avnish Kare on intensive care. What are all the tools which are coming up? All those things, recordings already I have sent you. You please go through once or twice, watch and rewatch. If any doubts, you put it in the group so that we can take follow-up live webinar on that if you have not understood. So today's specialty series 2 is mainly on pediatric radiology and its demonstration. What are all the things which are coming up as a screening tool, diagnosing tool, or monitoring tool? What is the basic understanding of that? For that, we have Dr. Praveen Shastri, very close friend of me. 2 years back, we met in Karnataka Medical Conference, IMA conference at Reva University in Bangalore. Hardly we had a just 20 minutes, not even 20 minutes panel discussion in that at the fag end of Sunday. Not many audience were not interested, but still we could able to deliver some good thing about AI. That time I met Dr. Praveen Shastri. He is a MD radiologist from Manipal University as a DNB, MA in MS, and he has got a European diploma in radiology and diploma in ICRI, FAGE, and MBA, and he is a coder also, and he has undergone a lot of training under Manipal Institute of Technology. You have seen his LinkedIn profile, you will know, and he has undergone some training, and he is evaluating AI models and developing AI models. So he has gone in depth to the innovation level of artificial intelligence as a creator or an innovator. So welcome, Dr. Praveen, for this. So here we have a learning, very basic learning, pediatricians very much interested, but they are digitally well built, their hospitals and clinic. They have got good digital knowledge, Dr. Praveen. So you can show them the details of the depth of knowledge, how the pediatric radiology AI tools are developing, the basic concept, each and everything. All the session will be recorded, don't worry. And it will be, you can see whenever you want, at whatever the time you want. And anything, Dr. Praveen, I have been added to you in the WhatsApp group of both the batches. He will be able to answer you whenever you are free. So with this brief introduction, I hand over this stage to Dr. Praveen for next 1 hour. After that, I will introduce our Dr. ATUL TIWARI, another faculty. He is also AI coder, AI innovator, and he is having his AI class. Since last 3 years, I am with him. He is a pathologist by profession, working in a Chittorgarh Medical College near Udaipur, and he is a representative for Artificial Intelligence Ministry as a advisor to the Rajasthan government. So he is also a very good coder. These people are mainly meant for AI advanced courses, but still I bought him to know you, to all of you should know about these things in the future, so that after this course, 1 month after you got enabled with this basic AI, though, then you can take these advanced courses from this academy. With this, I hand over the stage to both of you, Dr. Praveen and Dr. Atul. I will make you as a host. Please take care of our learners. Thank you.
Thank you, sir. Very good evening, one and all. So I would like to thank Dr. Deepak, sir, for inviting me for this session. As sir has mentioned, we'll keep it very basic today. We'll not get into the depths of how things are built or how can we contribute. But then today is all about exposing ourselves to the entire spectrum of tools available out there. Okay. With that said, I'll get to the topic per se. I'll just mute my video so that there are better internet connectivity. So let's get started. As sir mentioned, I'm Dr. Praveen. I have been an AI enthusiast since last 4-5 years, and fortunately I've been a part of Tata Group, wherein we've built more than 250 patents in radiology AI. So we have upwards of 250 patents in building AI solutions. So very happy to be here and talking to you all, and very glad to take up any questions at the end. So before we get started, these are my disclosures. So there are a lot of pros and cons. It's a very rapidly evolving field, as we all know it. So you might all, so any medical specialty might say radiology is not my cup of tea. They might say this is not my specialty, but especially radiology is something which you really cannot avoid, because in the era of evidence-based medicine, radiology and AI both are necessary evils. So may it be or not your forte, these are things that will actually add value to your clinical practice every single day. So I have no conflicts of interest to disclose, and this is not a sponsored. So any tool that I'm telling, these are not sponsored, or I'm not here to endorse them. It's always the contrary of it. And the perspective is always sticking to basics today, and we'll not cover anything really advanced. And there might be very seniors here, Dr. Atul, Dr. Deepak, sir. These are people who might know better than what is in this presentation. So since that it is a very rapidly evolving field, this is just the tip of iceberg that we will skim through today. Okay, so yes, why is today's topic really different or difficult? Because it is important to appreciate two very, very crucial things here. One is pediatric imaging, and the second is AI. In an adult, when it comes to imaging, in radiology, adult anatomy is always stable, right? So a normal chest radiograph of a 40-year-old, say, will look the same even 1 or 2 years from now. But pediatrics is very different. Especially, it becomes challenging when we build AI around it. Why so? Because a normal radiograph in a 2-year-old is fundamentally different from the same part radiograph in a 12-year-old. The anatomy changes, the ossification centers, growth plates, normal variants, all of these are continuously evolving. And that's what the normal baseline is wavy. It is not a stagnant one. That is one layer of complexity when we are dealing with pediatric AI. Also, the disease spectrum generally changes significantly with each class of age groups, right? Now, to this equation, add AI. Just when we begin to understand one model, there is a new model that arrives. You talk about vision models, multimodal systems, prompting strategies, workflow, all of these emerge at a pace which is really hard to follow. So that is precisely why the first is the child whose anatomy and physiology are continuously evolving. The second is the technology, which is rapidly evolving. That neither the patient nor the technology is a constant. And that is why today it's a really difficult task. So without further ado, let's jump right into the topic. Okay. I would like to begin with the real world Tony Stark, Elon Musk, and his exceptional invention of self-driven cars. Somebody, if they had told us a decade or two ago, 10, 20 years ago, that there would be self-driven cars, it would really be a science fiction. But today, it is a reality. Why so? Solely because of the technology, which is computer vision. Now, how does computer vision work? Which is very relevant to us. So how does computer vision work? It has n number of cameras. Hope my cursor is visible. So each camera is constantly refreshing and trying to find something. Maybe one camera is tuned to find people, one for the adjacent cars or vehicles, one for the signboard. So these things are constantly refreshing and they are on a constant lookout. Hypothetically, let's stick to signboards for now. The moment the given camera spots a signboard, right? There are no signboard, all is well. The moment it spots a signboard, a cascade of algorithms is activated. It starts to search its database as to what this given signboard could be. And if that signboard matches something that of a stop sign, the braking systems get flagged. Now, to draw oversimplified parallels with medical imaging, all the available solutions are on a constant lookout for a lesion in any given image. The moment it detects a lesion, it triggers a cascade of algorithm to match its database. And that is precisely why database has to be very robust. And if that lesion is something like a malignant one, it gets flagged with great significance. So that is how very superficially computer visions work. This said, let's now look at all the commercially available tools today. So there are n number of tools. The focus today I have emphasized upon is all the ones which are relevant to pediatrics. So we look into all of these, but everything comes with a freemium. They give you a few credits, you can use them for a few days, and thereafter you will have to buy tokens. That is more often than not, most of the solutions in this segment are based in that way. So that is something we have to keep in mind. So to begin with, you have something that is bone age estimation during AI. So what is this used for? Pediatric endocrine clinics, short stature workups, precocious puberties, or delayed puberties. So what does this do? When you upload a radiograph, bluntly, when you just upload a radiograph, it does all the calculations, does the heavy lifting, and gives you a bone age. This is probably very widely recognized and dedicated, and globally maximum number of FDA approvals have come under bone age estimation. This is a low hanging fruit. It's not very complex and it's not very difficult to pull it off. So skeletal maturity assessment, we have n number of tools. We will look into all of these together. So what I'm trying to show you here is a thing called Gleamer. So Gleamer is a solution which actually very confidently enables and predicts bone age and development. The skeletal age very precisely is demonstrated. So this is without AI. You can upload your thing also here, and with AI it becomes like this. So chronological age is 11 years and 3 months in this case. AI based, it will do all the heavy lifting. Grulich and Pyle system of classification is employed, and it gives us 15 years. So we can challenge it. You can start using it, and so the accuracy is up to 97% is what they claim. To begin with, the first tool is Gleamer. Most of these you'll have to register with your mail ID and start using it. The moment it stops, it stops. So this is Gleamer. Okay. Next, we have this amazing tool. This is very easy to use, which is called Rad Sherpa. This is really very nice for the reason that it is as simple as this. Automated bone age calculator. I repeat, this is Rad Sherpa. Okay. So how does this work? I will give you all of these again. Maybe you can take a screenshot of the synopsis slide. So I select a file. All that I have to do is select my X-ray, and just in case I give my tokens, I have exhausted all my tokens. So I would want you or urge you to do that. And just in case you want to, so you can give your mail ID. A few tokens will be free. Birth date and study date if you give, it gives an amazing report, which is upwards of 90% correct. So this is Rad Sherpa for you. It is as simple as this. Preferably DICOM format. If not, you can as well go ahead. So these are images taken in my center. So we can upload any, even JPG format will do. Okay. So these are, one was Gleamer and this was Rad Sherpa. We have multiple tools like these. I'm just highlighting the most proclaimed FDA approved set. Okay. So again, FISIS is an award winning tool which takes care of bone age. You can start your 7-day free trial here, just in case you are in an emergency center and you encounter a lot of trauma cases or medical legal issues also. So you just have to enter patient details. How does this work? Upload the image, increase the confidence, and finally, conveniently, it will give us based on Grulich and Pyle atlas. Okay. You can as well interact with the report. So the output is that of a decoder. It's like a GPT of sorts. You can start interacting with this, and that is how FISIS THYSIS. So we've seen 3 for now. So I'll just keep showing more and more images. Okay, so this again is similar. These are the tools when it comes to, yes. Now this was about gleamer and physis. The first one was Rad Sherpa, pediatric endocrinologists, or bone age estimation, skeletal dysplasias, and all of that. Now moving on to musculoskeletal system. This is very important, especially in trauma setting. So, of course, pediatrics and adults do not go hand in hand more often than not. So that is one segment wherein there is a huge, they are poles apart. So adult tools cannot be used in pediatrics, must not be ever used in pediatrics, because most of the times growth plates are mistaken. Subtle fractures are missed. So what differs? Subtle torus fractures are missed. Green stick fractures are missed. So that is precisely why we have tools like AZMed. Okay, so I will again show you how AZMed looks like. So this is again a FDA approved tool which is called as azmed.com. So you don't have to book a demo, that is for an institutional level, but again you get free credits. So the moment you see, there are only 3 things that the free version will help us reach. With this is also supposed to be very reliable a tool. Apart from this, the same very thing gives you chest x-ray solutions, measurements, and bone age also. So this is AZMed for you in the setting of trauma. So pediatric fracture detection is not equal to adult, because if at all you're not very precisely, explicitly telling the solution, it will more often than not pick these growth plates as transverse fractures. So there'll be a lot of errors, and MSK, pediatric musculoskeletal, is some place you have to be extremely cautious in taking the results by face value. It always must be taken with a pinch of salt. Now, suppose you are in emergency and there is history of trauma, history of fall from the bed, simple things like these, and there's a CT brain with no immediate access to the radiologist. That is when a solution called AIDOC comes into play. So the beauty about this is there is good amount of false negative rates. It might not be fixed, but it becomes extremely good in picking up basi-temporal, basi-frontal, cellular, all these second look detection, like easily missed areas are beautifully flagged. This coupled with, these are all bone skull fractures on CT head. This coupled with bleed, it not only tells that there is bleed, it also goes a step forward to characterize that bleed. Is it an SDH, EDH, IPH, or SAH? It will measure and then probably talk about the secondary complications of the bleed, if there is midline shift, if there is herniations. All of these are taken care in one go. This is AIDOC for you. So you just have to have the entire stack of axial images and upload them once and for all, and that is when it will give you a very reliable report. So it's like a co-pilot. So you, until you wait for the radiologist report, this will be extremely helpful in negative screening. So you can actually take it at ease or wait by time when it is a normal report under ADOC. So the best part is it is very efficient in flagging even sub-millimetric bleeds. 1 to 2 millimeter bleed also, which can be very easily missed on a naked eye. These are picked beautifully. So this is a depiction and the tool is ADOC. Now skeletal dysplasias, scoliosis. Again, we are still in musculoskeletal imaging. All of these are easily, very beautifully picked by a solution called Synapsica. This unfortunately does not have a free tool, What it does, if there is early degenerative changes, it picks all the parameters in line. If there is disc related problems, are these Schmall's nodes, if there is scoliosis, kyphosis, the angle, the Cobb's angle is also very efficiently picked. So that is all about Synapsica. Okay, moving forward, coming to very commonly encountered set of problems, chest related. So pediatric chest is one exception in the entire stack of solutions, wherein adult solutions perform very acceptably in pediatric individuals also. It is contrary when it comes to musculoskeletal, but adult solutions do a very decent job when it comes to pediatrics also. So here we have something called as QR.ai, proudly an Indian company which is doing really well. Their main thing was tuberculosis screening. So this is QR.ai. We had access, it's FDA cleared and also British approval, HIPAA compliant. So you just have to upload and it does all the heavy lifting. It has more than 70 pathologies that it can detect. So this is Cure.ai with a Q, Cure with a Q. So now look at the output in my given case. This was a 16-year-old chap maybe. So it will flag all the findings about, it will talk about atelectasis, calcifications. These subtle perihilar calcifications, calcified granulomas are also very ably picked, highlighting them. And here we have pleural effusion that is also taken up with a 80% confidence interval. We do something called a softmax, which will give us a probabilistic interpretation. So these are how confident is the solution in flagging these things. That is also very properly spoken about. Moving on, we have another solution which also does this. This is called Lunit. So this solution is called Lunit. First we spoke about Cure, then now is Lunit. This is Lunit for you. It also does a similar thing. What is extremely good about Lunit is, apart from the pathologies, the highlight for this is nodule characterization. So if at all you find nodules, pediatric hematonco and things like these, if you get a nodule, we are generally stuck if this could be a pediatric onco case with metastasis, or is this secondary infection having nodules. So that is when Lunit comes into play and it characterizes the nodules pretty beautifully. You just have to upload the axial sections into this. You have a few credits and it does a good job. So Lunit also takes care of X-rays to begin with. So look at this case. This is an adult actually. It has fibrotic changes, few air bronchograms here. So this could be chronic and this could be acute on chronic infective etiology. Look at how beautifully it gives that there is again here there are few subtle perihilar calcifications. So it is very reliable when it comes to chest. So this is the differential. You can actually enable or disable additional things. This is Rayscape. So this is Cure.ai, Lunit and Rayscape. This is the Lunit output. I have just cropped these and look at this. So if there is a nodule, it will create a 3D out of it. Two good companies are extremely efficient in dealing with pulmonary nodules. One is, as we discussed, Lunit. Second one is Aidence. So what does Aidence do? Aidence actually looks at all the margins. If there are speculated angular margins, then it gives you a probabilistic score of this being dangerous. So that was the entire spectrum of dedicated pediatric tools. We can go on and on. It is like chasing a dragon's tail. There is no end to this. So I've actually scooped out the most reliable ones and the most reputed ones in this segment. So you can take a screenshot of this if you wish to. So Gleamer is for skeletal bone automated age. Physis does the pretty much same. AZMed for fractures. Cure.ai for all the infective pathology. Lunit for nodule. Okay, and AI doc for CT brain, Synapsica for spine. We have open source things which are very good, which is Chester. Chester is also a brilliant tool. I have to accept that it is not for medical use, it is more for, so I just have to upload. This is, look at this. This is called a Chester. It's a radiology assistant tool. So if at all you're stuck with any weird looking x-rays, you can start. This is a free tool. So you can actually start using this. It will take its own sweet time. That is the irony. We're talking about AI and we get stuck with internet speed. So yes, the point is not to give demos here. That's it. So we have that. Okay.
Praveen, by that time it takes some little time.
Huh.
Can you suggest our pediatricians which hardware to better for this image analysis to upload the scans and all to do it very fast? Which is the Apple, Mac, which settings, features will better?
Okay.
Can you highlight that?
Perfect, sir. Very, very valid question, sir. Sir, I'll actually refrain from that and focus here actually. Most of the solutions are built for Windows ecosystem. That is the catch here. And if at all you are able to, and it all depends on what access you have to. Like, uh, meaning, what is the ecosystem in your hospital that you're working, right? Preferably,
Okay.
you have to go for DICOM images only. Only if
Okay.
DICOM are not there. DICOM is the source images in which X-rays or CTs are taken. So first thing, we have to always wait for DICOM images. If we do not have DICOM images, the second best is JPEG. So apart from this, HTM, all of that are not supported by most of these tools, but most of them are compatible with DICOM. This is first. Second, if at all you want to view it, you have something called as Radiant Viewer. I'll just show you the viewer, which is very relevant. So no, I'll just show you that. So this is how a Radiant Viewer looks like. So this viewer, you can actually import any set of cases. So this is a very free tool for 14 days. You can actually after that uninstall and reinstall. So it is eternally free. So Radiant
Okay.
Viewer, if you are, and the best part is any image you put in here, you can convert it into DICOM and then put it into the tools available there. So that is how it works. So very valid question, sir. I'll
And
just
regarding
continue.
the features of the personal computer, what you suggest for, because many of our doctors have their own bigger hospitals, corporate hospitals, and they are
Yes, sir.
doing Dr. Subramania is doing chest X-ray courses, live courses.
Okay.
So I think most of the time where we fault is whenever doing image analysis is very slowly it will take. So any
Yes, sir.
recommendation for any devices you prefer, like
Sir,
which?
not really, sir, because all these speed, processor, all that matters when you're building solutions. For using it, it solely depends on the processing speed and the internet. That's it. So I do not have any particular specifications for the end user.
Okay.
It's like a movie per se. So if the internet is good and the RAM is good, I think we can do it. But I have a lot of specifications if you're planning to build. I think that we will cover in the end. Okay.
Okay.
Yes, sir. So I'm very particular, sir, that we are not very specific when it comes to end users.
Okay.
Just like the format is specific, DICOM is what we have to be comfortable with. The best part is DICOMs we cannot see by itself without a viewer.
Yes.
It will just look like an icon. Whereas JPG will be able to see the image, but that might not work with all these AI tools. That is a catch here.
Now any SCMD devices are come with by default DICOM mode only.
Yes, sir.
If you
DICOM
take
is
alter
the universal image
universal.
acceptor. Yes, sir. Okay, so now after coming to this juncture, I'm sure you all are comfortable with one thing, that there are lot of things to choose from. There's a lot of, so think of AI as a grand buffet of technology. There are too many things. Everything is overwhelming. Lot of buzzwords and complex ideas. Some are really tempting, some are super cool, but they will not quench your thirst or it will not serve your purpose. No matter how spicy and things get, something ಎಷ್ಟೇ ಇದೆಲ್ಲ ಚೆನ್ನಾಗಿ ಅನ್ಸಿದ್ರು ಕೊನೆಗೆ ತೃಪ್ತಿ ಆಗೋದು ಇದರಿಂದಾನೆ. ಸೊ ಸಮಥಿಂಗ್ ಫೆಮಿಲಿಯರ್ ಅಂಡ್ ಕಂಫರ್ಟಿಂಗ್ ಲೈಕ್ ಅ humble bowl of curd rice. Coming back to the basics is all that matters. So here we have exposed to the entire spectrum. Let's go deeper, okay, and like try getting back to basics. So what is that it will set apart the people here today from the rest of them is everybody are hyped about collecting tools, chasing the new ones, the newest ones, focusing on the additional hidden features of the software, and their focus is all tool centric. So we all begin with that phase only. As we mature, we get to understand that there is no end to it, right? So what we all have to focus today, the crux of today's talk is this: we have to focus on the workflow rather than the tool. If we have only 2 or 3 tools, it is all about how we use the tool. Focus on how to extract the best out of each tool, and it must be problem centric. So this next segment is the crux of what I want to present today. It is not about the machine anymore. It is man behind the machine that matters. We don't need 15 knives, 12 peelers, 2 mixers, and oven to cook a dinner. All so you don't need 17 subscriptions to make sure you're getting exposed to the entire spectrum of radiology tools out there. One chat GPT, one Canva, or a simple Claude is enough. Now let's focus on how we can use it. Before that, a story. So we'll keep it light. We'll wind up in the next 30 minutes, but we'll make sure that it is. So imagine you're a PG resident and you are on call over the weekend. It's Monday morning and you're swamped with work. You even skipped breakfast for rounds. It's already 1 p.m. now and you're really, really hungry. You have a new intern posted in your unit. You request that intern to get you something to eat at 1 p.m. in the afternoon. The request is simple: get me something to eat. So he walks down the stairs, goes to a nearby coffee store beside the hospital wards, and gets you a pack of Good Day biscuits. Would that serve your purpose? Absolutely not. So in the same example, the best way to instruct this intern would be to establish all the facts that you were on call over the weekend, you skipped breakfast, you're having a rough day, and you generally have lunch between 1 to 2 p.m. every afternoon. Tell him that you're a vegetarian. Ask him to get lunch from XYZ restaurant, preferably South Indian cuisine. And then you need it before 1:40 p.m. so that you eat it and be back to work at 2 p.m. You shall be really surprised as to how useful this intern might turn out to be every single time. All the solutions that we have are just like that intern in their early postings. So we have data that says more than 800 million users are actively using our LLMs. May it be Claude, Sonnet, Grok, GPT, anything. But less than 7% of them are really satisfied. The reason is not inefficiency of the tool. It is all because of one thing: we do not know how to ask. So there's always a scope for improvement, for better prompting. And the next segment is all about prompting like a pro with radiology perspective. We have done extensive research on LLMs, SLMs, and VLMs, and we've come up with a foolproof strategy which has been published, and we've spoken about it in the US RSNA, which is the Apex conference globally. So we've spoken about this, and that is what I would like to emphasize upon. So what is a good prompt? I'm sure other speakers will have covered this, but I am talking about the same with the radiology perspective. So you tell it the role or the context. So you start every prompt every image that you put. So this is applicable to all vision capable LLMs. May it be ChatGPT, Grok, Sonnet, Claude. So everything, let's keep it grounded to ChatGPT for now. You have to give it context. How will you start? Act like you are a pediatric radiologist with 2 decades of experience. And then you ask it to interpret the given image. Then give it instruction that it belongs to a, say, 8-year-old male child with recent history of trauma. And then give it data that clinically there is swelling. And how would you want the report to be? You want it to be concise, crisp, succinct, or you want it to be very elaborate and discussion like. So if you give it in this very order, that is the best way to converse with the tool. So prompt like a pro is a must to get very accurate results. Moving on, this is very important, and it will help you maybe not just in radiology, in other things also. So we stress tested all the available tools, right? As to if we upload a pediatric image, who will do well? Okay. Most widely used, ChatGPT. Multimodal LLMs are what we are talking about. Vision capable, context grounded large language models. We did that with every single tool available out there. So one is good for reasoning, the other one is good for multimodality. So everybody claims, but these are the results for pediatric cases. Now, how do you ask? We did a beautiful experiment wherein you ask freestyle. You just talk to it like you talk to a colleague over a cup of coffee. This is freestyle versus structured. In structured, we have something called as tired prompting. You give it 1 step, 2 step, 3 step, or a 4 step data, which is better. Then you have iterative. What is iterative? You ask a question, you get a response, you refine the response. So you talk, and then both of you during the course of conversation come to the conclusion. That is iterative. And finally, reference enhancement. This is the key, like limelight here. Referenced thing. So we will look at all of these. Free versus structured. Free is interpret these extremity images and provide your assessment. This is free. Structured is the thing that we told about, prompt like a pro. You tell it what it is, how should it think like, analyze it, give me findings, measurements, give a proper impression, give me relevant classification, additional findings, and what would you recommend? Would you recommend a surgical intervention starter? So this is structured prompting. Now going deeper, how should your structured prompt be? It must be 4-tiered structured prompting. Generic is, again, it is like a freestyle. Describe the X-ray. Semi-contextual is 2nd-tier prompting. So there is a scope for improvement in your prompts at every single stage with radiology perspective. Semi-contextual is interpret AP and lateral views of the knee and leg of a 8-year-old child, male child or a female child. That is semi-contextual. Then you come to specific clinical, which is 3rd-tier. You talk about the indication in detail, and finally output also is mentioned. That becomes a fully guided multi-tiered prompting. So always multi-tiered prompting is way better than iterative or freestyle. This is first step. There are no surprises here, right? We all could understand. Anybody who is in this course knows that multi-tiered will perform better than free. But one challenge that repeatedly kept happening, especially when it comes to pediatric, is too much of hallucination. You know why? Because database, most of them are trained on adults. There is no very limited, specifically pediatric databases. So it will hallucinate. What were the types of hallucinations? Measurements were fabricated. There was always overcalling. Hyper elaborate classification, which was not necessary, overdid it. Growth plate errors were almost 1 in 10 cases. And finally, soft tissue interventions. This kept happening no matter what system it is. This is a thing in pediatrics. And the best way, the brilliant way, how our team of data scientists came up and tackled this is by a thing called reference image enhancement. In this, what you do, please bear with me for this one slide. You have a finding. You're uploading it to AI. You get an output. This is routine. All that you have to do is go to Google and download a normal image of the same part of the same age, same gender. That is all that you have to do. This is called as referenced imaging. Just by giving the AI what a normal looks like in the given scenario, there was a drastic improvement on the output. And this is a study we've published multiple places. Look at the amount of difference that it has caused. Detection accuracy spiked up by 45%. Hallucination dropped by 42%. Better clinical contextualization, and iterative took the largest time because you have to keep chatting to come to a place, whereas referenced brought down the time to diagnosis also by 34%. So structured and referenced prompting has the best result. I'm sure you knew referenced structured would be, but referenced prompting is a new finding that I would urge you all to start using. It will be very useful. And finally, of all the solutions out there, we did this almost a year ago. This is how it looked like. So ChatGPT was overall effective across all strategies, followed by Claude, which was very good in reasoning, but picking up or the vision capability had limitations. And finally, we have Grok. So this is the key slide wherein referenced prompting is a new thing that we are coming up. And for the ones interested, we are trying SLMs versus LLMs. So LLMs are trained over few billions of data, right? We are building radiology centric SLMs, which are just like a Chrome extensions, which are very lightweight, which are trained over few millions, 8 million, 12 million. And there are studies that are ongoing to show SLM, which is curated maybe for a musculoskeletal rad or a pediatric rad, performs equally well as compared to a very established large language model. So that is a study we're doing. So that probably falls into advanced category. And now everybody here, they've done their course and you're invited to collaborate in a AI project, or somebody has invited you as an SME, subject matter expert, in something that revolves around pediatric imaging. The next few slides are, I'll just go really fast through it to make sure that few things are properly covered. Okay. Yes. So what are the things that these are things that we learned. So always choosing the right problem is harder than we think it is. We always are dragged towards hard to crack problems, resource intense problems, very catchy ones, but they might not have real world use. Focus on less glamorous ones. Something like a simple fracture detection on chest x-ray would be way more impactful than a fancy CT problem, something like neoplasm stage 3 versus 4. That does not have a great impact. So something which solves for pain is always better than something which is a good to have tool. We call it the analgesic versus vitamin. Analgesic solves the pain. Vitamin is a good to have tool. So just to draw oversimplified parallels, you go to a fancy restaurant, you have the menu in front of you. You as the subject matter expert has to choose what food you're ordering. So you could actually order something like a dal khichdi, or you could go for saffron risotto foam Dutch truffle, which is very fancy and niche. So something like this is simple, nourishing, and mandatory. Everybody understands it, and it solves for hunger. So these are examples that I'm talking about. So when you have the driving seat, you have to focus on things like these, because we have burnt our hands doing this and learning the hard way that it will not yield a lot of results. So these are all vitamin problems. So these are glamorous, niche, only a few understand it. It is very resource demanding. But it is true that the chef wins awards. It takes time to prepare. It impresses the journalists. But bottom line, nobody is less hungry after something like this. So do not chase fancy solutions whenever you are involved in building AI. Go for the simplest ones, less glamorous ones, so that you solve for a problem. Next, for all the pediatric oncologists here, I have a few things. My wife is a pediatric oncologist, so I was happy to chip in today. So it is extremely difficult to build around onco. Why? Basically, we have human anatomy, which throws a level of challenge. There are a lot of anatomical variants. That is your first level. Second, early cancers appear in a different way as compared to advanced cancer. Same HPE thing. In early stage, it could be just one line of enhancement. Whereas in advanced, when it comes to radiology, there could be necrosis, hemorrhage, everything within it. So this is something that the model will get confused. And finally, two things which appear spot on might have two different HPE diagnoses altogether. So that makes it extremely challenging to. So these are all anatomical variants. Over and above, these are all, what if I tell you, I cannot convince my model telling this and this are the same squamous cell carcinoma. That is how radiology wise it becomes extremely challenging. And finally, this is also enhancing, this is also enhancing. One is squamous cell carcinoma, the other one is a plaque, verrucous plaque. So even though they look similar, HPE is way big. That is why I would urge everybody, when you are involved, to refrain from anything around onco. And beautiful thing, we have tried this hundreds of times. In India, it is always difficult. The Indian scenario is not ideal. We have 0.3 Tesla machines or 3 Tesla machines. We have a open slice, dual slice, 2 slice CT. You have a 512 slice CT. This spectrum is what makes India very, very challenging. So the stellar Western solutions underperform with Indian images. This we have seen hundreds of times. So all the solutions that I showed you will underperform for sure as compared to the benchmark claims that they call. They'll tell 98%. It might be 1 in 4 cases will be wrong when it comes to Indian images. So we've seen firsthand. The contrary is amazing. If you find any Indian solution that will do amazingly well in homogeneous Western data, this is something we have seen. So craft for India, conquer globally. So Western solutions become a joke when they are real-time tested. It's like driving a Ferrari on a village road, and that too in monsoon. That is how it most commonly is. Moving on, how should your approach be? So whenever it is you're building AI, there are two things that we look at. You get bounding boxes as an end user as to where the pathology is, right? How does the AI understand is by heat signatures or grad camps. So this is what AI is understanding. This is what it is showing you. So there must be a sync between this, and while you're building tools, this must be the guiding lamp and not this. All the patients with the AP views, ICU patients, malpositioned patients, were showing higher pneumonia rates. Not because it was reading the lung pattern, it was reading the label as AP or PA views. So that it tries to do, because if you remember, all of us in our histology labs during internals, we have tried not just looking into the scope, we have tried all the marks on the slides in the corner, the numbers, all of that. So AI also does that in real time. So for that, we have to look at interpretability. We have to look for heat signatures. Has it understood what it has to understand? This must be the basis for everything we take a call on. Finally, what is edge deployment? We are keeping it basic. Now, what is edge deployment? Earlier, hitherto, you had to send your images to a server. That would be sent to cloud. All the processing and results would be done under cloud. And then that result would come to us. What are the constraints? Data, the first is security, right? You had to share the patient data, all of that. Making sure that they will do all the white mapping, they will erase all the credentials, and then they will send it to cloud, right? You had to rely on that. And then internet, and then the time, you needed time for going in and coming back. Now the new concept is edge deployment. What is edge deployment? Example, algorithm is in the machine that is doing, machine of the console. Imagine taking a chest x-ray and that very moment alarm goes off if there is pneumothorax. That is edge deployment. You take a CT scan and if there is bleed, the alarm goes off. So the AI tool has been installed in the machine, not elsewhere in a computer. So FDA has already approved pneumothorax and bleed detection for edge deployment. Matter of time when multiple of these will get into the machine per se as an upgradation software. Right? We started with the big example of Tesla. So I would want to give this video of how things can go south. This is a case which is not, it has been taken down from YouTube by the Tesla company. But look at what has happened. This is in China. The Tesla XY vehicle went out of control. It was confirmed that the driver was also inebriated. He was trying to call people for help. It went bonkers. And this is what happened. So it ended up killing many people and causing significant harm. So moral of the story, no solution is even now 100% accurate. Even that occasional error when it comes to imaging, if that leads to loss of life or morbidity, who has to own up? Is it the developer, the company, the hospital, or the patient who chose it? It's all a grayscale. So non-negotiables, never trust AI solutions blindly. Always verify it. And please refrain from uploading patient details. You never know how these things will pan out in the future. And the critical thinking must always be with the doctor himself. And it will be a very good sidekick, but not take the driving seat all in itself. I've deliberately kept it less jargonish. I would love to go very much in depth if you guys love it. So a sneak peek into the future of AI. So we all know Instagram filters, right? All of us are very comfortable seeing these Instagram filters. Puppy filter. What is this? Augmented reality. What if there is a hypothetical amalgamation of augmented reality with radiology and AI? This is what it looks like. And this is not in the future. A company called Medivis has already done it. You can superimpose patient's scans on himself with sub-millimetric accuracy so that no tumor is missed. So that in the future, if this becomes very widespread, you do not miss the tumor. There are no R2 resections. It is always R1 resection. No inadvertent nick of vessels because it is seen live. And look at the learning curve. Postgraduates can practice on this very patient with Mallampatti 3 maybe, or they can do the surgery on the patient hundreds of times before they actually do touch the patient. So this is what is happening to radiology in the very near future. So with all that said, I think we're spot on. I'd like to conclude stating that it will definitely augment medical or pediatric imaging, but the art of healing shall always be human. Thank you so much.
Thank you, Praveen. I think you have given a basic concept about the computer vision and how the AI works in radiology in a beautiful way. Hopefully, our learners who are there, they have got some idea. Probably what I wish as a course coordinator and request is every month we have a free webinar in the same time night. If you
Okay.
are free, you please show some one or two Cure AI tools live demo and upload some common pediatric chest X-ray, the common things, pneumonia or any intraventricular bleed. So
Sure, sir,
so
we can do
that
that.
our learners will have a little bit of experience, the feeling of
Definitely, sir.
experience of That's my
Yes.
request, Dr. Praveen.
Sure, sir. Let's do that. Let's do that.
Any questions from learners? Subramanya, are you there?
Yeah, I am there, but there are no questions. Only thing is that they can learn by exploring. What they can also ask is, apart in the prompt, they can add not just the report. Do what next investigation is ideal. That is the most good prompt that one can ask, not just the interpretation. For example, something is not clear, they can always ask, can I go for ultrasound? Can I go for CT, lateral X-ray? This is a big dilemma for most of the pediatricians. And even in CT, Dr. Praveen, you would agree with me, half of them don't know about what is HRCT, what is conventional CT, what is contrast CT, what is CECT,
Beautiful, sir.
whether
Very
I
true.
should take CT in inspiration, expiration, prone, supine. The protocol is never discussed with a radiologist and what lesion they are looking for. And I think AI can ask them to choose the correct investigation. Is it with contrast is okay, without contrast is okay? Because it makes 3 to 4,000 rupees difference for a patient. Because when they order, radiologist cannot refuse.
Beautifully said,
Yes,
sir. Like very, 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 very valid points. I would like to actually add more to this. So, in the question, or you have a basic image with you, uh, I think we can just build GPTs for protocoling. This is a very real problem that you brought up. We can actually build GPTs as to what is the ideal protocol for a given case. So, that I think a radiologist can. I will do that myself and share it across. You just have to tell the condition and it will tell you exactly all the things. Should you go in for a contrast? Would HRCT be better or CECT be better? And what are the prerequisites in the given case for the contrast? These are amazing points that you brought, sir. And yes, so meningitis can never be diagnosed without contrast. Plain, we can only see complications of meningitis, but enhancement is what we look for when we want to look for pediatric meningitis, leptomeningeal enhancement. So getting a plain scan is of no use when the clinician is suspecting meningitis. Likewise, any study with the neck, plain is of no use if at all we're not. So things like these we can actually build, and I think this is a very doable thing. And while you're prompting, if the last thing, the actionability is also included, act like a pediatric radiologist. What study is being uploaded? What is the clinical data? How do you want the report? And the fifth part, it is the multi-tiered prompting structure, wherein what do you want me to do immediately? So
I think, Dr.
actionability
Praveen,
focus is also.
I would just add, please, all of you, I will share with the group soft copy of Felson's diseases of Ranchanology, Sutton, Granger. I think if they can just add these three, then the whole world is with them, and then the entire radiology is at their side. So, Dr. Praveen, I'm sorry, I'm encroaching onto your area,
No,
but
sir,
that's
sir,
what happens.
beautiful.
Granger and Sutton textbooks are like Harrison and Nelson for medicine and pediatrics, respectively. If you upload them, plus upload the Felson, then I think that that AI is forced to give within that limits rather than going by some vague references. That would add an
the
advantage.
radiology book, Subramanya, Felson.
I will just
Yes.
type it in the group. Felson
You
textbook
share.
of
No, if
Felson.
you have a soft copy, you please share in the
I'll
WhatsApp.
share. I'll share.
Your Google
But
Drive link.
Granger and Sutton, I don't have. Dr. Praveen must be having. I think we'll share. That's one. Because right now the Telegram is banned, and many of them were in Telegram because they were large PDFs. So
No,
I
you
was
could
not.
have put it in the G Drive, no?
No,
And
I'll
share it.
just see because whether I have downloaded or whether I don't have. I'll just check that. That's
No, it
one
will be
point.
in your mobile. If it is in
No,
Telegram,
you
it is
can
in a
even
mobile
prompt
file.
it like no, there is no need to upload the text. You can say you choose the references of these textbooks while you are giving reports. That it can browse.
You please
Somebody would
put
have
it in the
uploaded.
chat box,
Yeah.
Subramanya. What are the Felsons and the Grangers, the textbook title, so that we will search and find out in some of this thing.
Okay,
And
that's
Praveen,
I think I'll have to leave,
regarding
sir.
that custom
I
GPT
have
of
a.
radiology, Dr. Praveen, are you there?
Yes, sir. Sir, I am on another call now. If you
Okay,
mind,
okay.
I'll leave for now.
No problem, no problem.
We can circle back.
If
Thank you
possible,
so
you
much,
can join
everyone.
later, and otherwise, I will converse with you.
Yes, sir. Yes, sir.
Right,
Thank you
Dr.
so
Praveen.
much.
Thank you very much for
Pleasant
your
interacting with all
wonderful
of you, sir.
uh,
Thank you. Bye-bye.
explanation about the pediatric radiology subspecialty. I think we need still more regarding your custom GPT. We will have a free live webinar. That time, I'll invite you.
Yes,
Thanks
sir.
a lot, Dr. Praveen.
Thank you, sir. Bye-bye.
And
Thank you,
anything,
sir. Bye-bye.
learners, if you have anything to chat, you put it in our respective batch wise. Dr. Praveen has been added. Whenever he is free, he is going to reply our concerns. So thank you, Dr. Praveen.
Thank you, sir. Bye-bye. Good
So
night.
with this, we move on to the second session of today. I invite Dr. Atul Tiwari. He is my very close friend. Just 2 days back, we were in Solapur. So he is a coder, he is a pathologist, and is a assistant professor in Chittorgarh Medical College, Rajasthan, and also is a consultant, AI consultant to the Ministry of Rajasthan. Dr. Atul, without wasting much time, please explain about the role of AI in pathology, pediatric pathology, especially complete blood count, pediatric smears, how to analyze the lab reports, and especially your favorite subject, pathology. Over to you, Dr. Atul.
Thank you. Thank you so much, Dr. Deepak, for introducing me, and a very good evening to you all. That was a wonderful session. And Dr. Praveen, in fact, he helped me he has created a very nice base for you all for image understanding, and in a very simplified way, that some of the things now I can take from his talk only for the reference part. But yes, we'll come back to that part once I start discussing my slides. Dr. Deepak, can you please confirm if my slides are visible?
Yes, sir. It is visible and it is full screen.
Yeah.
Just carry answer. No problem.
Okay,
You are audible also.
So
nothing is hiding.
Yeah. Okay. Thank you. So very good evening. So as you know, I'm Dr. Atul TIWARI. I'm an associate professor at GMC Chittorgarh, as well as an additional nodal officer for Government of Rajasthan for AI/ML policy in medical education. So with regards to AI in pathology, specifically in terms of pediatrics, if we discuss, there are multiple roadblocks. I'm starting my talk with the roadblock only, because like you see in the radiology, there are multiple tools that you can try out from day one, at least create a free account and try out something. There is no such thing for, unfortunately, for pathology. There is a big reason for that. We will come back to it. But for my talk, I have designed it for even for prenatal and fetal till neonatal, as well as children, and then for hematology, pediatric cancer, and microbiology part as well. So with a few disclosure that yes, I will be showing you some proprietary and company made tools, but obviously I'm not associated with any one of those. These are the tools that I felt you should be knowing about, or at least I saw that in research grid they worked nicely. So the pediatrics as well as laboratory medicine or pathology per se, both of the things are where AI in healthcare comparatively lagged. And why I'm saying it, if we go with the FDA approved machines and devices data, there are more than almost around 1,500 FDA authorized AIML devices by the end of last year, out of which 76% belong to radiology fraternity only. So that's why that in that talk, sir, was able to describe you so many FDA approved tools, but hardly there are 17% tools that are actually have been cleared for pediatrics. But if we talk about tool which is cleared for pediatric pathology, then there are very hard to none. Even for FDA approved AI sepsis tool, that is also clearly says that they did not study it on children. So the consistent lens for every domain in this talk would be like identifying the clinical problem, building an AI solution, trying to put some evidence that it has worked nice, and what are the limitations. Obviously, for any fraternity, it is true that AI won't replace them, but having a knowledge of AI will give us an advantage over those who don't know anything about AI. So that being said, it is a very famous paper and a video by Faisal Mahmood Lab from Harvard. It was published in Nature somewhere around 2 years back. I'm just playing it. There is no sound. So basically what it does is each and everybody, like if someone talks to you that, oh, he's a pathologist. So you might be thinking that he deals with slides and slides all the time. So this is the thing, like you can say a chat GPT for slides. So Dr. Faisal Mahmood Lab proposed Patch Chat 2 years back. Again, here is a caveat that it was not performing well for pediatric pathology, but the same algorithm can be applied on pediatric pathology if someone really wants to build upon. The thing is, we need to have that much of data and computational power to train. So here what is happening on the left hand side, the whole slide is being scanned, is scanned on whole slide scanner or is being seen in real time. And on the right hand side, real time data is being checked. And even what is the next step, what should be the next step, it is being predicted. And accordingly, one can take the next step decision. So someone in the chat asked, like, for pathological references, will the prompts help? Yes, definitely they will help. Obviously we don't have that kind of access like for path chat. It is like in research grade, and some of the hospitals only have that kind of access. Indian startups are also there, like Turocrats, someone from Mumbai or Pune, I think. You can check out turocrats.ai. They build something like this only. But if someone really wants to build a tool that is surrounding for pediatric pathology per se, then obviously they need to give a huge data set, because pediatric pathology lacks it in case of histopathology. So by the end of this session, what I have planned, that you should be able to describe the current real-world applications of AI in pediatric pathology as well as in lab medicine, some of the deployed tools, identifying the clinical ready regulated tools versus some of the research type prototypes that are out there, and distinguishing if AI is genuinely helping some values or it is just an hyped tool that is out there for you to, someone is asking you to try out. And lastly, recognizing the Indian context also. So first, let us start with prenatal AI. There are tools like Panorama AI. They have created something very nice for NIPT, AI enhanced tool for NIPT, which provided machine learning on cell-free DNA fragments, which did 22 Q chromosome deletion. Ultimately, it resulted in a positive prediction value that was raised from 24% to more than 50%, and it is a very good jump just only by the addition of AI. And then comes in case of neonatal AI, there is a rapid genome. In rapid genome, the AI was very well researched and integrated. There is something called as rapid whole genome sequencing by Reddy, and Fabric GEM is another one. Both of these are international tools. It increased the basically decrease the TAT and increase the time in which one can give the diagnosis. So there is a shorter diagnostic time out, the shorter TAT. In case of hematology, we also have something like for a tool like this. I will come to that tool when I will be showing you the Indian context. So the worldwide famous tool is CellaVision, where whole slide is scanned and a PBF is analyzed using something called as computer vision. So now you have been already introduced with the term computer vision in radiology session. Sir has very well introduced you with how does computer see with an example of the Tesla automated car. So in the same way, like pathology, histopathology or hematology, these are the same kind of branches like radiology, ophthalmology or dermatology. These are image-based branches. So here we mostly deal with computer vision as well as deep learning. So here each of the cell is being scanned and analyzed or categorized, whether this belongs to maybe like a sickle cell or if it is a blast. So then we can easily filter out those cases. But some of the caveats with this digital smear is there. We'll come back to that after a couple of slides. Then in case of oncology, machine learning CNS tumor classifier is already embedded in WHO CNS 5th version. There are intraoperative diagnosis that has reduced intraoperative diagnosis to under 90 minutes. Then comes newborn screening. So collaborative lab integrated reports. They have reduced that. Basically, they have helped us in post-analytical pattern recognition, and they have reduced false positive. So the false positive have been decreased from 0.26% to 0.02%. That study was done on more than 1,70,000 newborns. Lastly, in case of microbiology, the culture plate is still the go-to tools. Yes, we have backtech and other measures for faster diagnosis nowadays, but still these are only in the big labs or the tier 1 city medical colleges. So we are still using the culture plate. So AI assisted culture plate trials also caught through MRSA cultures, and that's why the negative predictive value is very good now, and we can exclude that. So in terms of microbiology, using the plate reading, it is very helpful. So now that you know that there are tools, so but one should be aware about if those tools are actually clinical ready or those are just in research mode, because if they are in research mode, they will fail sooner or later, because there are n number of variations. If someone is testing a US research grade tool in Indian scenario, that is mostly bound to fail. We need to retrain that model for Indian scenario as well. So that is why one should be able to differentiate what is clinical ready tool and what is experimental or research grade tool. Like if something is approved by FDA, yes, that is clinical ready. If it was done on multi-center prospective validation of the on real patient, if it has been done, if it is integrated into an LIS, then it gives us an advantage. One thing that one should never forget, that is explainable AI. In the radiology session, you also saw some that heat maps, the orangish reddish color maps were there. So the explainable AI must always be there, without which one I would say bluntly say that one should not even use a single tool which does not explain anything or verified by explainable AI. And lastly, it should be validated for a defined population. For example, I told you, like if tool has been used approved in US, then there are chances that it might fail in Indian scenario. Similarly, for the research grade tools, yeah, mostly you know that there are published area under ROC curve is very good. It looks good in research, looks too good to be true. But when we deploy the same thing for real world experimentation, it fails very badly. The reason is same, that most of the time that study has been done on single center or retrospective data set only. There is no prospective study. There are no regulatory clearance has been taken upon. So it lacks a lot of licenses and formalities, because of which the model might not perform that well. Black box is one of the major disadvantages of research area if it is not providing the explainable AI counterpart. And yes, last but not the least, that I always say that I also demonstrate something in a 1 hour session or a 2 hour session. I will select hardly 10 or 15 images to showcase how to train a model. So in that case, model might overfit. By overfitting, it means model is mugging up everything. So when we do multicentric study, when we do study on a larger data set, then this overfitting can be counteracted. So what are the regulations we have and we haven't cleared yet? So as you can see, most of the tools, like more than 70% tools that are cleared for radiology, and hardly 3% tools are there for pathology or lab medicine. And then there are certain tools like for PACE AI, Galen, and Arteria AI. These have some very nice algorithm that are there, which are FDA approved for histopathological whole slide imaging analysis. But yes, none of these are freely available. There are some tools that are freely available, which I will showcase you after I end this presentation. But it would be a little bit difficult to try out in a local laptop or a desktop, because as you know, pathology is mostly about image analysis, and image analysis, if you try it in local laptop, then it would be very difficult, because you need a very high-end graphics card. So there is a gap, as you can see from this chart also, that there is a pediatric gap of FDA approved AI devices also. Then after that, we will go step by step for each age group of the patients or children, like starting from the prenatal or the fetal diagnosis. So I told you that there is an there is an enhancement to the basic or classical NIPT using cell-free DNA. There was by Panorama AI, and another one is by by Natera Panorama AI. So basically, they use SNP plus probabilistic model that was trained on more than 2 million cell-free DNA tests, and that increased the PPV values to more than 53%. Then there is another convolutional neural network that is called as AID. It learns from cell-free DNA fragment, but it does not count it. So this is a limitation of any convolution neural network, that generally they do not count. We use a different kind of framework for those. You might not be aware about that. There is something called as YOLO. You only look once. That is a very nice framework for counting. But if you don't know, that's okay, because most of the time you will be using it on a ready-made tool only. Because building such kind of algorithm is tricky, and you must know programming for that part. So after this NIPT or cell-free DNA, then there is a fetal genome interpretation part. In this one also, Nostos Genomics had created AON, or however you pronounce it, AION. Basically, it helped us in a faster whole genome analysis part. And similarly, another tool that is by AI Marvel, that is called as AI Marvel by Baylor. It is more or less knowledge driven, but it is working on explainable CNV classifier. So all of these are genomic analysis tools, and they perform very nice on whole genome sequencing, and they have reduced turnaround time from days to some days. Then comes facial phenotyping. So there is phase 2 gene or deep gestalt. So it is a next generation phenotypic for dysmorphic syndromes. So there it is helpful for, specifically it is built for pediatric in case of children's face, analyzing children's faces. But then there is regulatory reality also, that these are mostly not FDA cleared as a diagnostic tool so far. So again, these were the evidence as well as limitation, like that these are not FDA cleared as of now. Maybe later on they might get clearance. In research grade, they have shown some good accuracy. Each of these tools have shown a nice improvement, like AID NIPT has increased the PPV value. Panorama AI has also improved the PPV value both more than 50%. AION has caught many causative variant in the top 5 for 100% and solved the sum of the fetal cases. Similarly, for phase 2 gene, 91% of the top 10 syndrome accuracy, it has been achieved. In case of India, MAT Genome and Liliac Insights, they offer NIPT validated for Indian population. So they have the data set. I am not aware about if they have trained their own model, but I'm hopeful that in future, if they have not done already, then in future they will similarly incorporate AI studies in their own analysis part. Then comes neonatal screening and genomics. So in case of neonatal screening, as we read in the first introductory slide, that collaborative lab integrated reports, these are not for diagnostic purpose, I would say, but for post-analytical multivariate pattern recognition. What do this mean? We basically reduce the false positive. So false positive have been reduced from 0.26% to 0.02%, and this caused an increase in positive prediction value. So it means that there was more than around 90% false positive reduction across all of the newborns. So there are less number of worried parents as well as children, or there are comparatively lesser number of follow-ups. Those were not required. So then per disorder machine learning model, we can make it, but it is little bit tricky because most of the cases, pediatric data for pathology specifically, they have certain guardrails, like you all know, there are limitation even for blood cells, like in newborn from day 1, day 2, day 3, every other day there is a separate range. So if I want to build a machine learning model for hemoglobin only, let's say, then it would be very difficult for me to set a criteria. So that is one of the major challenges. While in case of adults, it is mostly in a range like male, female, pregnancy, and lactation. All of these have a decent range that has an overlapping value. But in case of children, daily, then after like monthly and yearly, all of these values change. So per disorder machine learning model are a little bit tricky. For genome analysis, I told you like rapid whole genome sequencing has been done. It is by one is by Redis and another one is by Fabric GEM. Both of these work nicely on genome to treatment analysis. So automated diagnosis, the time has been reduced to now like 13.5 hours. Previously, it was in days. So now the national programs like in case of UK, the Genomics England have been decided like to include it in their national program. The several screening tools are trying to incorporate till 2027. And why the AI rule is here? Like I told you that most of these investigations they used to take days. So now the time has been reduced from days or weeks to hours. That's why it is necessary. And most of these tools are still working on collaborative efforts only. They are not yet FDA cleared. So there is another question that comes into mind is a very common one is neonatal sepsis. And interestingly, you can see here it is sepsis by prognosis. It is by it is called as immunoscore, but they also claim explicitly say that it is not evaluated in under 18 years of patient. So it is also actually an adult only tool. So there is an hero deployed exemplar that is heart rate characteristic monitor. So it is FDA cleared and the only RCT validated tool in this domain. There were some RCT done, 22% relative reduction in all-cause mortality was observed. So that is the only FDA cleared tool that is out there, but from lab perspective. But all of the others are research grade tools only. Even like we have seen from Indian scenario only, I can say like we taught some of the critical care doctors about how can we create our own AI in AI detection tool for sepsis, early sepsis detection. But even in those cohort, I was not able to teach them in detail because these things still require a lot of programming. And because this is a time series analysis, I don't know how many of you are aware about time series analysis, but sepsis is a thing from which you can understand if you have not already. Like whenever we train a machine learning a model, we train it at a fixed point of time. What were the values? For example, if I want to train sickle cell disease detection. So I can take blood sample at any given point time and I can take images from that sickle cell. But in case of sepsis, these kind of things not happen. We study over a period of time. What was the value at the first hour, or the hour of admission? What was the value of first hour, second hour, third hour, and so on and so forth. This is called a time series analysis. And that is comparatively tough. So yes, again, the evidence versus the limitation, you know that only one tool that is actually approved, but most of others are only in research grade. Rapid and whole genome sequencing as well as Fabric one, both of these have reduced the turnaround time. There is India has no national universal newborn screening program, at least I don't know any of that. And that is one of the major opportunity if someone wants to work upon. And National Sickle Cell Mission has already screened more than 6 crore people, as per the study suggests. So now it is up to us how we generate that particular data, because I'm also from south of southern Rajasthan. I have seen there are so many patients that are for thalassemia or sickle cell reason which are here. So this comes to one of my forte, like pediatric hematology and blood, that I have seen many cases. But the thing is, if I want to integrate artificial intelligence on my own, the one of the major caveat here is scanning the slide. Scanning the slide is a huge limitation as compared to radiology, because as you already know that in case of radiology, all of the things are digital from day one, be it CT, be it MRI. I don't think now hardly anyone would be doing the classical X-ray, that taking out the printout, or sorry, filming the print. But nowadays, everybody is moving towards the digital X-ray only. But in case of pathology, once a diagnosis is made on the glass slide under the microscope, after that the pathologist work is done. But AI works start here, taking out the slide, scanning it, and then creating a digital storage first, later on annotating the slides, and then training that particular all the slides for future diagnosis. So that is an extra work that anyone will have to do, whoever wants to work in the field of AI in pathology. And this is the major caveat because of which AI in pathology research are quite behind in terms of as compared to AI in radiology. But nowadays, some of the machines that are there, for example, I told you one about Cellavision, another one is Olo. There is an Indian company called SHASTRY.LAB. I don't know if some of you are familiar with. It is a Bangalore-based startup only. So all these three, they scan the slides and they give the digital hematology images, through which one can easily identify the pediatric lesions, like which I can think of is identifying sickle cell, thalassemia, or ALL cases. Like in most of the young age group, ALL is more as compared to AML. So I would say lymphoblastic detection is quite important for those cases. But yes, choosing the right tool at the right time is also important. For example, when I'm saying thalassemia or sickle cell anemia, yes, the gold standard still is either HB electrophoresis or HPLC, not on the whole slide imaging. But why I'm still saying so? The reason is sometimes if we don't have the parent history, like at least I can say, I work in a government setup. Most of the time, the patients that are admitted here or the children that get delivered here, we don't know about their parents' status of the hemoglobinopathy, even though we belong to a belt of India where hemoglobinopathy is common. But the CBC report sometimes guide us. PBF most of the time guides us. And if the pathologist has seen it actually very nicely from the point of view that this is a newborn case, or if hemoglobinopathy can be there, and he actually wants to rule out, then it's like he can see. But if AI is integrated, then even the 1% of the sickle cell can be detected very quickly, and later on the patient can be, or the child can be examined thoroughly. So similarly, for peripheral blood smearing, there are tools for bone marrow examination also. There is a convolution neural network based tool by Morphogo. It is a China-based tool, if I remember correctly. Yes, yeah, deployed clinically in China, but it is not FDA cleared. And their accuracy, they claim to be 87%, but as you can see, the study was done on 213 children only. Similarly, by Scopio FF bone marrow aspirate study that was done in 2024. Both of these are limited value study, but that's why I always advocate that it is time to create a digital archive of pathology slides, be it peripheral blood smear, be it bone marrow aspirate, because if we create a digital archive, then only we will be able to train on millions of images, which is actually required for creating a nice model. And why do human still sign it? Again, one of the major caveat that I have seen is that even though in case of adult, if I train a model for peripheral blood smear or bone marrow for blast detection, it fails badly on pediatric morphology. The reason being blast and reactive lymphocytes sometimes in pediatric pathology, they are mostly confused, and AI is also getting confused. Even trained pathologists, sometimes they require special stains or ISC or flow cytometry to differentiate between these. So BALL, I told you in the previous slide also. So this is one of the major research area where one should look upon. So BALL blast detection is one of the benchmark thing. There are multiple benchmark data sets that are derived from children because BALL is common in children. So this is one of the area where we got the data set for leukemia detection, as well as once the onco case has been treated for MRD detection. So for both of these, there are algorithms which are also being used or explored in flow cytometry as well. As far as I can recall, one of my contact also in from CMC Vellore, Dr. Fenendra Dattari, you can check it out from LinkedIn. He is also doing his research on AI in flow cytometry for MRD analysis, that is minimal residual disease analysis. And they are using AI in that flow cytometry. It is showing some promising result, but those are still research grade tools. Lastly, for body fluids, like for pediatrics, one of the most commonly used body fluid, that is CSF only. So glow site CSF counter is one of the tool that is actually research grade proven. So again, all of these, most of these tools are for research purpose only. Some of these are FDA approved, but for adults or for different types of diseases. For example, in case of flow cytometry, most of the tool are able to differentiate between AML versus ALL. They are not going deeper into BALL, but Mayo Clinic did worked upon it nicely for creating BALL MRD. And here comes that sick tuple that I told you about. They detected, they used AI in their machine, and it detected blast nicely, although the sensitivity specificity claimed to be 100%. But in terms of pediatric pathology, we still need to figure out with huge data set. So this, I already told you a couple of slides back that thalassemia and sickle cell morphology, it is India's most common single genetic disorders that remain underrepresented. And these are underrepresented in Western training sets. That's why we need to build our own training data set so that we can detect these diseases early. So now comes the pediatric cancer as well as computational pathology part. So here, in case of molecular, now we are going towards from slide to molecular analysis of these cancers. So here, methylation classification system that is actually based for CNS tumors. Nowadays, they have integrated machine learning classifier that has been already been codified in WHO classification. Then there is intraoperative and imaging features are also there. Nanopore classifier is a laptop diagnosis in which does in less than 40 minutes. Maybe you can just Google about this device. As far as I know, AIMS and PGI, they were both trying this particular device in their research work from last year, or last 2 years at least. Then there is image classifier for all round blue cell tumors. One of the round blue cell tumor that you know is neuroblastoma and Wilms tumor. Both of these are pediatric tumors. So for these image-based classifications are made and they are performing nice in research. As you can see that area under receiver operating curve, they are showing more than 96% accuracy. But then again, they fail with when we go for licensing or if we try in different labs. One of the major caveat here is when we scan a slide, then there is a variable that is called as scanner, which type of scanner I am using versus which type of scanner you have. Then there is second thing, that is there are multiple companies of which slides are being scanned. So the quality of the staining is also another issue. And then there are many technical issues as well in between. So these kind of issues range from pre-analytics to a post-analytical, and because of which there is no homogeneous distribution of image quality amongst different labs as well. So that's why these kind of tools fail. How we can leverage it? If someone has created a model, we can fine tune it with our own data set. That's how most of the labs, AI labs, they improve the model. Then there are multiple foundation model that has been released, one of which I had shown you in the beginning, that is called as PathChat by Modela AI. Another one is by same Fazal Mahmood Labs only, Varchow, Uni, Conch, and Pro Gigapath is by Microsoft. All of these are these are foundational model. Foundational model means they are specifically trained for pathology only. But the thing is, again, it is mostly trained on adult tissue. There are hardly pediatric pathology cases on which they have been trained. So then what could be the solution? Like what I found in some research, like Australia, they are doing some prospective study on trying to incorporate zero childhood cancer, so that from the beginning only, early stage detection of cancer to survival going survival free. Basically 2 year survival free period, they are planning to increase it to a decent percentage. Then there are some registries like this DKFZ. I told you this is about CNS tumors that has already been integrated. Similar to this is another one that is called as Rapid CNS or Robin, which is again based on methylation of the class for tumor detection. So this is a similar comparison of all these tools, like WHO CNS5 tumor that has been integrated, that is DNA methylation classifier. It is very well approved, while others like which are performing nice or decently, they are not approved. So this is just a summary slide. Last but not the least, that is microbiology or infectious diseases. So here I told you that there are we are doing mostly study on culture plates. So either culture plates can be used for bacterial analysis. So most of the study has been done on MRSA analysis. And there is another type of section for microbiology, that is for parasitology and tuberculosis. For parasitology, there is EasyScan Go that has a decent sensitivity and a specificity now for malaria microscopy. But for most of the parasitemia, for pediatric range, again, you can see that this kind of sensitivity decreased from 91% to 57%. Similarly, for TB, like in radiology session, you have been introduced with Query AI. That is actually very nice tool. But again, the radiology tools, they have been decently integrated with AI radiology part also, but not in terms of pathology or this microbiology. So we are still in maturing phase or infancy phase, you can say. And I'm hoping that within a couple of years, these will improve to such an extent that these can be used in a similar way, like radiology, people can integrate their AI tools in the radiology machines. So as you can see, Query AI, now you know, it is the world's first AI chest X-ray CE cleared for TB in children for 0 to 3 years. I'm sure you know that it was initially doing a study only on TB only. Later on, they have trained their model for all of the other similar diseases. So now India is building their own diagnostic AI tool. So SIGTUPL is one of those. Yes, it is mainly focusing upon adult pathology still. But yes, that being said, once the tool has been built, the machine has been built, it is just a matter of time that they will be training their machine for pediatric data also. So I'm hoping that from that domain, some good outcome will come soon. Queer AI, you already know, it is for radiology. AI Indra for cervical cytology. And lastly, MolBio or TrueNat is for RT-PCR. It is battery operable chip for RT-PCR. It is endorsed by WHO for TB and rifampicin resistant adults as well as children. That was all of these tools were built in India or by Indians. And there are certain data set on which India is working, like Genome India from ICMR or DBT. Then there is National Sickle Cell Anemia Mission, newborn screening, and last but not the least is ABDM. So now again, this is a summary slide. So they mostly it is this is like challenges unique in India versus opportunity that we get. So like tropical sepsis mimics like dengue, malaria, strep typhus, enteric fever. These are not available. These are not there in the Western scenario, or they are less in number. But in Indian cases, we frequently see it. Let the rainy season come, and there will be a bombardment of dengue and malaria cases. So if we have data set for these kind of diseases, we can train our own model and use it in our day-to-day life. Similarly, for beta thalassemia and sickle cell, these are common in India. I told you it is common in my belt as well. Then malnutrition as well as late presentation of shift. So hematologic and biochemical reference ranges are a little bit deranged. So this is one of the major challenge where we can work upon. And how we can work upon these challenges like SIG-tuple, we know, Queer AI, Genome India, all of these are there, National Sickle Cell Mission, and lastly, ICMR's dataset. So each one of these can take up any challenge and start working on these challenges to make a nice solution that would be made in India. So Indian rule book is being written now. As you know that ICMR has also updated their ethical guidelines about use of AI a couple of years back only. CDSCO medical device software draft was revised last year only. Niti Aayog and India AI is actively working on making our own indigenous AI models as well as AI dataset. So India AI has AI, something called as AI Push. You can check it out. It is open access. You can also register. If you have your own data set, make it de-identifiable first, and you can share it on India AI so that other researchers can also try out and build some models. If you don't know how to make model, or if you have built some model you would like others to try out, you can host it on India AI website. So that way, not only your work will be recognized with the government of India, it is helpful for others also to validate as well as use that kind of work in their own setup. Last but not the least is the DPDP Act and ABDM mission. Both of these are now in force. Like this year is a gray zone year where it is not being forced upon, but I'm sure that from May 27, one will have to respect DPDP Act word to word. So a couple of slides I had hidden like about one of the prompt and another one about the image analysis, because in the radiology session you already saw a very nice example of how images are being analyzed using the Tesla example. For prompting, a similar type of slide was shown in radiology session as well. So for here also we can use something called as tiered prompting. But before tiered prompting, one must not forget that there are certain guidelines which I did not include, because I'm sure that by now you know how to write a prompt. You should give context like I'm a pathologist or I'm a pediatrician, something like that, and then give your after giving the role, give the context like what do you want to do, how you want to do, what should be the outcome. So there should be a structure to it. And then you can see, like, either you ask it simple query, like describe this peripheral blood smear, it would be very generic. And going towards the fully guided, like generate a comprehensive report, finding impression, diagnose, differential diagnosis with blast percentage, lineage call, dysplastic figures. So if I give what I want in detail, or if I'm explaining it in detail, then I would get a structured answer in response. That being said, as compared to radiology, you can't just take out an PBF image or a histopathology image and go to ChatGPT or Claude and ask about a report. It will fail miserably. It will fail because let me be clear. Since I have told you so many times that radiology was digitalized from step one. That's why Google, Facebook, or this OpenAI, Claude, all of these have so many digital data. But in terms of pathology, images, histopathology or hematology, the images were not there. Second thing is, while a CT scan might be of 50 MB, 500 MB, but if I compare a single patient's digital slide, it might be of size from 5 GB to 15 GB. You can just imagine how can I host a 15 GB slide for a single patient, and if I want to train upon, if I need 500 such slides, how much computational power I would require. Even the best of the best GPU that one can afford right now is like it is RTX 5090 that is used for these kind of model training, and it is somewhere around 8 lakh rupees in India. You can check it out on Amazon, and that can also host hardly 500 MB images. So how can I host 15 GB of image? I need to break it down to multiple segments of images. That is called as tiles. And that's why it became very difficult to train images. So even if you use prompting for ChatGPT or Claude or any other LLM, please make sure that if you are attaching any histopathology image, you need to describe it little bit yourself only. It will not be able to identify it correctly. So I will just check out if I have 5 minutes time, Dr. Deepak, because it is hardly 10 minutes left. If I can give a brief hands-on demo.
Yeah, please show, Dr. Atul.
Okay, thank you. So actually that was all about it. And I wanted to show you two things. I'm a little bit short on time. One of which is like pediatric reference interval. So as I told you, like in case of pediatric, we have a major challenge that there are very different ranges as compared to adult. So what I did was I simply asked ChatGPT or Claude, you can ask it also in a layman language, that I want to build a single self-contained HTML file. You don't know anything about HTML, that is also fine. The key term here is pediatric reference interval interpreter. That you know, it is your domain and it is my domain only. So you can just ask that make an app that can, I want to build an app that can be used as a pediatric reference interval. So I have, just to save some time when radiology session was ongoing, I just built it at many places like Claude, ChatGPT, like every free tool that are out there. I tried on those. I will show you just single prompt, and then I will show you how I built it. Can you see? I didn't give that fancy prompt, that long prompt. I know that this particular website that is called as Google AI Studio, I'm sure Dr. Deepak knows that this website has so much potential that it itself is a detailed workshop of more than 3-4 hours also. But just to cut short, I can show you that this is a single line prompt. Create a pediatric reference interval app for laboratory medicine, pathology, and hematology, specifically designed for clinician to quickly assess age appropriate reference ranges. And then it built me a nice app for like hematology. It gave me a tabular information. Yes, it is not complete right now, but and I'm still not sure that whether it's accurate or not, because I just built with a single prompt. If I had that reference interval, for example, I don't know about like whether Nansen has those ranges, but for in case of pathology, we mostly use author is Desi. Desi is pathology, in that there is a table for Indian scenario, the lab ranges values for hematology. So we use those. So if I had those in handy, I would have given in with my prompt and I would have asked it to make that particular table or app. But similarly for renal or for electrolyte, all of this, it built just by using a single prompt. But even after that, if someone don't use Google AI Studio, because if you are new to it or be any reason, I just gave the same prompt to ChatGPT as well as Claude, and it built me a nice single page HTML file which I can open in Google Chrome, Firefox, Mozilla, anywhere, and I can simply select here the like hemoglobin value, male, female, age. And since this is a child-based app that I asked, that's why it is showing me days, months, as well as years also. So if I set it to like 3 days and 10, so yes, it is showing me that it is the low hemoglobin value, and then the reference interval for each of these. This sometimes will lack, like as a pediatrician, you might have also faced that most of the labs that are out there, they give ranges mostly for adult-based scenario, not for pediatrics, or not, at least definitely not for this weekly or even monthly ranges. Nowadays, within this development of AI, most of the labs are using AI generated for templates also. So that's why these kind of things have been incorporated in some of the big labs, but not all of the labs are still using it. So if someone wants to use it, he or she can build tool like this or any tool like this. So before closing to this app building, let me just quickly show you. This was AI Studio. I'm not going into detail today because that would be very overwhelming. I'm just showing you that this is a very free tool by Google. You can build any app, not just pediatrics, not just AI in pathology. You can build maybe AI in radiology or AI for your pediatrics daily workflow only. So here, when I open this particular website for the first time, it might ask you for some license agreement. You just need to click on I agree, like you do for all of the softwares. But yeah, here the prompt area. So basically, you just need to write the same prompt here and click on, if I type something, here is an option to build, and it will start building the app. That's how I built that particular app that I just showed you. This one, it is free to use, free to try, but there are many things that you will learn over a period of time if you are really interested. Now, the second tool that I wanted to show was, this is called as Google Teachable Machine. So you can search on Google Teachable Machine. It is used for image analysis part. So unlike radiology, I can't show you a ready-made tool where you can upload your pathology images, where automatically it will be classifying disease for you. It is not there. At least not that I'm aware, because and I can say not there because I have tried many ones, and those require huge computational power, and it is not possible on consumer grade laptop. So this is Google Teachable Machine. And when I try to open any new project, I need to click on this image project because I'm analyzing image. There are other domains of it as well, like audio project, that I feel can be helpful in your case. Like I can say, Dr. Deepak, if you are aware, if you know that cry analysis project, something like that, it can be done in this audio project section also. And the last is the pose project, that is mostly used by to test out whether yoga pose is correct, or orthopedician suggested some exercise if it is correct or not. Those kind of tools can be done. In case of image analysis, if I click on this, I need to move to standard image model. And here is the basic simple UI where how I can train my model. I need to just upload few images. For example, if I just upload a few images of lymphocyte and a few images of blast, just to identify if my case is or a peripheral blood smear is lymphocyte or blast images. So here, these are some sample lymphocyte images. As you can see, I uploaded hardly some 5-10 images. In real world scenario, I need to upload more than thousands of images. So this is how a lymphocyte look like. And similarly, I will upload some blast images. This I downloaded from Kaggle only, but if someone has their own data, they can try out with those also. Let me try with sorry. So those who know pediatric, ALL ontology, specifically hematology, from hematology point of view, they know that there are different types of blast. And let me just quickly upload a few images of blast. So I had hardly uploaded 10 images of lymphocyte as well as 13 images of blast. And I can click on train. There are some advanced settings, but for now, I'm not going into that. I'm simply clicking on train. What are those different options or settings? I don't know whether it will be covered in your course later on, or Dr. Deepak, he knows better. He also knows how to use Google Teachable Machine.
This is more of advanced for them.
Yeah, so that's why we are not going into detail, but if someone is later on interested, then they can build up their own model. So here the model has been trained, and if I load any sample image, for example, this was not trained. So it can easily classify that this belongs to a blast category. While I'm showing you that a model was trained in a few minutes as well as it was able to identify correctly, behind the scene, there are a lot of things going on. And it is, as Dr. Deepak said nicely, that it requires a decent knowledge of AI as well. So it is not a 1 minute discussion or a 1 hour session. It requires a separate hands-on session. But that being said, if someone really wants to check out some free tool or options, then this huggingface.co is a website where HIST AI is a tool. HIST AI is a company that releases free of cost histopathology models. But so far, I'm sure that they have not released any pediatric specific data set. So you can see that there are hematologic data set. So out of which, how many will be from pediatric category that you will need to figure out. These are available free of cost, but their size is very large. It is difficult to try out on a consumer grade laptop. So that was all from my side. I hope I was able to make some sense to you, but I know that I put a disclaimer that there are no such tools that you can like try out right out of the way, like just now today or tonight only.
So, okay, Dr. Atul. I think it's about 10:30 now.
Yeah.
Dear learners, see, this is just a tip of iceberg that we have given in this specialty, because most of the tools have been tried with the data sets from outside. So now people like Atul, Dr. Praveen, they are loading our own data sets from the medical colleges and all, and they are doing fine tuning the models which are taken from the outside, and they are doing transverse learning also. Probably in the next 6 months or 1 year, we are going to come up with the models which can diagnose, not only screen, which can diagnose and monitor our tools. And very important thing that Dr. Atul showed about the development of our own tools, custom tools by using Google AI Studio, Google Teachable Machine, all those things that once you undergo this or watch all these videos of 5 modules, what we teach, maybe after 1 or 2 months, we can go for an advanced one, wherein we will make you how to train the models, how to take small project, what is the capstone project and all in your domain. Like, for example, Dr. Sagata is there in the neonatology domain. Dr. Subramania is there in pediatric domain. We will take each and every capstone project, and one of our senior person will be lead you to make a capstone project. All those things you can present it in various technology conferences, AI summit, and you can get a good rewards also, because these capstones projects will give you a lot of highlights. You maybe wonder, I think I posted in our Smart Hill Nexus, the 8th standard boy presented a paper on maternal and child health in Solapur, and he got the best prize award. He got the iPad, the pro version of iPad from the organizers. See, such a type of now learning is not depends on the age. It is how you make it. See, we have around 120 doctors to be present today. Only 20 are there till 10:30. That means you are paid, but many people are not utilizing. That is my pain. Anyway, for one people also, I am ready to share the knowledge. Even if it is 11 o'clock, that is not my this thing. My motto is to give the knowledge and the rest of the things left to the learners. Anyway, maybe because of lot of reason they are not able to log in. The video will be sent tomorrow by evening. I think if you the session is open. If anything, please unmute and ask questions. Otherwise, we'll make it a day today. Thank you, Dr. Atul. Yeah.
Thank you, Dr. Deepak. I just would like to add one more line. Since all of here till 10:30, I would like you to all be very now vigilant about your data as also try to make at least your own digitalized copy of your own data, so that if in future some ready-made tools are available, you can start making something out of your own. The one of the disadvantage that I face here at my working place or area surrounding it, that we are still using the pen paper only, and most of the data is not digitalized and they are not even archived. So it is a good time that if you are using EMR, try to make your copies of data, so that in future, after 1 year or 2 years, this can be of useful to you.
Yes, Dr. Atul. That is what our course, first 4 hours of our course is how to do digitalization and all. So if any question, no question is there, tomorrow we have pediatric cardiology, pediatric allergy and ENT disorder. We have 2 eminent faculties. They are using AI tools in their life and they have done a wonderful thing. So please log in tomorrow. Don't miss. It's an important session. And we have a demo of a AI-powered digital stethoscope from IUSync. For 15 to 20 minutes, they are going to show you how it is used. And please use that tool in your future for digital health record. So many things can be diagnosed with that. With this, I thank Dr. Atul TIWARI and all learners, so 20 learners who are there for this good live meeting session. I think with this, we are going to end this meeting. Thank you very much. So tomorrow again, we will meet once again. Thank you, Dr. Atul. Thank you very much. Hope we will have an advanced course with you. Once we'll see that, take the expression of interest from this learners, and we will move about. Thank you very much.
Thank you.
Thank you, Atul. Thank you. Bye. Bye. Good night.
Good night.